Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegrams. Marcus at home is back with our next international guest, who will again allow us to look at the COVID-19 pandemic from a global perspective. He comes from the country that is leading in SARS-CoV-2 vaccination, while we in Germany are still discussing the pros and cons of different vaccines. My co-moderators are Professor Sören Becker from Saarland University in Homburg, Germany, and Anja Scheuer, who's a medical student, again, from Homburg in Germany. My name is Gunnar Heine from Frankfurt in Germany.
Professor Leshem is the director of the Center for Travel Medicine and Tropical Disease at Sheba Medical Center, as well as a clinical associate professor at the Tel Aviv University School of Medicine in Israel. He's also a guest researcher for the CDC, as well as a consultant for the WHO. Thank you so much for joining us, Professor Leshem. We will see a presentation from you first, and then we will afterwards go ahead and ask you some more questions if you haven't answered them already.
Thank you. It's a pleasure to be here. What I will try to present in the next few minutes is the experience we had from real-world impact of COVID-19 vaccine rollout in Israel. Begin by a brief introduction to Israel demographics. Israel has a population of about 9 million. 6.8 million are Jewish citizens, and 1.9 million are Arab Israeli citizens. The birth cohort is 176,000, and the total fertility rate of Israeli women is the highest on the OECD, 3 children for every woman, which makes us a very young nation. Our healthcare expenditure, on the other hand, is very low compared with our GDP, only 7.4%, which makes us, we don't spend a lot on healthcare. But lastly, the life expectancy of Israeli residents is very high compared with other OECD, 83 years, men and women, which ranks us number 7 in the OECD and in the entire world. So that's our starting point. The other starting point is from our healthcare system. Israel has a national health insurance law, which means that every legal resident in Israel receives all medical care with a very, very low co-payment, several dollars for months, several euros, and the medical coverage is universal. So it's independent if you're employed or unemployed, where you live, how much tax you pay. If you're a legal resident in Israel, you will get full healthcare, and it is provided by healthcare funds. The healthcare funds, as you see in the picture on the right, started back in the beginning of the 20th century, and when Jews came to Israel from Europe and started as organizations providing healthcare in the community, and evolved into 4 non-for-profit organizations through which the Israeli country provides healthcare to its citizens. They are all very strongly community-based. All are fully electronic medical record, which means there's a lot of connectivity. So here's the structure again. There's the Ministry of Health, which is funded by the Ministry of Finance. And the Ministry of Health finances health funds, all 4 of them. You see the largest is called Klalit, 54% of the citizens. And on the other hand, it funds hospitals of the Ministry of Health. So we have a very low number of beds per capita, but still we manage to provide relatively good health care and longevity. I want to focus on the information exchange system, which allowed this, which was a key factor in allowing Israel to provide the vaccine so rapidly. So it's the world's largest connected community through people and technology because of the number of Israelis and health electronic medical records that are interconnected, all 50 hospitals, all of the healthcare funds, the HMOs, the prison services and all community clinics are all interconnected. So if I sit in a hospital and want to see the medical record of a patient that came to the emergency room, I can open everything. All his lab results, his echocardiography, his CT results, everything is available. And you see here all hospitals around, the 4 health funds, all are interconnected through a medical record. So regarding the COVID, from the beginning, we experienced 3 major waves. The first one now looks very minor, the one in the end of March during the Passover holidays, where we had a peak of 700 patients. Then in the New Year holiday, the Jewish New Year holiday, we reached 10,000 a day, and which resulted in a lockdown. So we had a lockdown in March, a lockdown in September, and our 3rd lockdown came in January during our 3rd wave, when we also started vaccinating. Overall, from 9 million, we have 764,000 confirmed cases and 5,600 deaths. And here is the second factor that allows Israel maybe to respond to this outbreak differently than other nations. The Israeli public and government are very well drilled or practiced to move from regular life, from normal state of living, to emergency, to being shot at missiles, or these conflicts that we experience through the years. Make the public understand, and the government, this is not regular times. We need to lift logistic, administrative, and bureaucratic blockage and move to emergency operation, which is what happened during the COVID outbreak. So Israel very rapidly moves to the vaccine queue. We don't know exactly what happened between Israel and Pfizer. The contract was not published, but it is plausible that Israel asked Pfizer to provide enough doses to cover all the population as soon as possible, and in exchange allowed Pfizer access to the aggregated, de-identified data. So Pfizer gets access to the data on vaccine effectiveness, but not to individual patient files, only to the aggregated data to look at the vaccine impact. How does the Israeli supply chain for the vaccine works, and why was it so successful? Because from the manufacturing facility, it is flown to Israel to a deep freeze facility owned by a large pharmaceutical company called Teva that focuses on generics. And Teva had this logistic facility for other purposes, but it was repurposed for the national immunization program for the COVID vaccines. And from there on, once the vaccines are thawed, you can rapidly move them to the healthcare fund community outreach locations. Now, we said these healthcare funds have a long, tens of years experience of working in the community. Every community has a clinic that knows the names of the patient, their age, their address, have a application, have their number, so they could invite the patients that were prioritized, the people that were prioritized, invite them over to the community clinic and calculate the number of vaccines. Very interesting, yeah. So this was the logistic. And then in end of December, what the Ministry of Health does is they create a prioritization. They say, first, we will vaccinate healthcare workers, residents of long-term care facilities, persons over 60, and persons with severe disease. But then within 3 weeks, they move to all other risk groups and to other frontline and high-risk exposure, like teachers and first responders, police, firefighters, etc. Then 2 weeks later, in late January, they open to age over 50, and also to high school students. The reason was they wanted high school students to be vaccinated so they can take their matriculation. Then they moved on in early February to the entire population. So you see, within 1.5 months, within 6 weeks, Israel gets high coverage of at-risk prioritized and moves to entire population. The first person to be vaccinated in Israel is the Prime Minister. Benjamin Netanyahu is vaccinated here at Sheba Medical Center. He receives an immunization card. And there is a communication lesson here. When your head of state receives the vaccine first, it tells your citizen that the vaccine is safe and effective. There's a public health communication message here, in my opinion. So how well did we do in terms of coverage? You see here the proportion by population that's covered. And if you look at the first line that rises, it's persons over 60 years old who received the first dose. You see that by the first week of January, we reach 80% of these persons received one dose, which is phenomenal because they are all going to be protected 4 weeks later by the second dose, fully protected against severe COVID. Then you see the other lines rising. This graph only ends in beginning of February. There's no later data of this type, but you see that slowly rising proportions of other population. If you look at the number of daily doses we administer, you see that at the peak, end of January, the peak capacity was 2 doses for every 100 Israelis. That is almost 200,000 doses every day provided, but you see that there are ups and downs at this capacity. So what is our current status? I apologize for this. This slide is a bit distorted, but what you can see here in the green is the important part. You see that in our population of above, overall we provided 4.7 million received 1 dose and 3.1 are fully vaccinated with 2 doses. But in the population above age 50, you see that 83% already received 2 doses and are fully vaccinated. And if you count also the 4% that recovered from disease in this population, you see that almost 87% are fully protected against severe COVID. So moving to some impact and effectiveness data, I will start with some ecologic data that was released. This is a preprint from Weizmann Institute from the Weizmann Institute, a group that looks ecologically on what higher coverage does on levels of disease. So on the bottom panels, panel E gives you proportion vaccinated from age under 60. In panel F, in the light blue and dark blue, you see first dose vaccinated age over 60 and second dose covered age over 60. So you see by end of January, almost 80% of people aged over 60 received 2 doses. Those are the bottom panels. Now, how does this correlate with disease levels? If you look at panel A, it's new positive cases. The blue line are persons aged over 60 and the orange under 60. And you see there is a lockdown, right? The dotted line gives you the third lockdown. So you would expect a decline after a lockdown. But you see that the decline in persons over 60 continues even when the decline in younger persons stops, the number stops dropping and even starts rising. So the lockdown stops working for those that are unvaccinated because people are meeting, but it continues to work to vaccinated person because they get higher coverage levels. So panel A gives you all positives, panel B moderate or severe, panel C is hospitalized, and panel D is new severe hospitalized. And you see that the decline continues in all panels in persons over 60, while persons under 60, there is a continued rise. Moving on to patterns on this panel, what they did is they compared early vaccinated cities with late vaccinated cities. So again, on the bottom panels, G and age, you see the proportion vaccinated with 1 dose and with 2 doses. And you see that in the early vaccinated cities, very rapidly they reach a high proportion covered with 2 doses. And again, you see that persons over 60 in green line, there is a drop in disease levels, both positives for A, hospitalized for C, and severe for E. Panels, these are the panels on the left. You see a drop in all measures, whereas the young people continued rise because they are not covered. On the right sides are late vaccinated cities. These are cities where people were more hesitant to get the vaccines, and then they got the coverage rising slower, which you can see on the bottom panel age. The level of coverage is slower. And you see again that the decline in disease in persons over 60 happens later compared with the persons under 60 in brown. So moving to another ecologic analysis that was published several days ago in the MMWR of the Center for Disease Control. And what you see here is comparing people that are mechanically ventilated in the entire state of Israel that are over 70 compared with people that are mechanically ventilated under age 50. So on the top panel, you see the coverage levels. And you see that for the over 70, the black columns give you the proportion vaccinated. You see that by early February, almost 90% received 2 doses that are aged over 70, while in the light blue, you see the persons that are under 50, and you see only 20 to 30% of these younger people are fully vaccinated by beginning of February, by February 9. Now when you look at the figure 2, the bottom panel, you see in the light blue number of mechanically ventilated age over 70, in dark blue number mechanically ventilated age under 50. And you see that when we get high coverage in people over 70, the number of mechanically ventilated stops rising and start dropping. While you see these unvaccinated, we see more and more people get mechanically ventilated. And if you look at the full black line, that's the ratio from mechanically ventilated over 70 to mechanically ventilated under 50. You see that this ratio drops, which tells you there are less people over 70 mechanically ventilated and more people under 50. So moving on to data that was released by the Israeli Ministry of Health in end of January. This is only looking at people who are fully vaccinated 7 days after dose 2. And what you see on the top row, people aged over 60 in years. In late January, we had 740,000 fully vaccinated. Now, how many of them got COVID infection? You see the total 530. However, it's a very low percent. Only 480 of those, 480 were not even hospitalized. They had a positive swab, but they were not hospitalized. And if you look at the hospitalized, from these 700,000 people, only 21 were hospitalized in severe disease and only 3 died. These data are even more pronounced in younger people. By end of January, 387,000 were fully vaccinated. Only 250 were infected, and only 3 had severe or critical disease, no deaths. So these are the early data showing vaccine effectiveness, but ecologic. Then a few weeks later, a couple of weeks later, the Ministry of Health shows some analysis of effectiveness, and these are all at all parameters. We're seeing 1 week and 2 weeks after those 2, a very substantial decline, over 90% protection for all parameters. So moving to some specific vaccine effectiveness analysis. This one is a publication that we were able to publish from Sheba Medical Center in the Lancet. We published that now a couple of weeks ago. And it was the first publication globally to show real-life vaccine effectiveness. What we did is Sheba has about 9,000 health workers. And through the months of December and January, many of them received the first dose of the vaccine, and then completed the second 3 weeks later. So what we could do is divide them to unvaccinated and vaccinated by period after the first vaccine. And now if a health worker was unvaccinated and then became vaccinated, we counted the days he was unvaccinated and events during the unvaccinated days. So we were able to get the rate per 10,000 person days of infections in unvaccinated and compare it to post-vaccine by day after the vaccine. And what we saw is that adjusted to the epidemic period, because in late December, we didn't have many cases in the community. In late January, we had almost 10,000 cases every day in Israel. So we had to adjust. And then what we saw is that we saw that during the first 2 weeks, there wasn't a real decline on the top panel of positive cases. But on week 3 and on week 4 after the first dose, there was a 47, a 65, and then an 86% decline compared with unvaccinated in the rate of infections. And when we looked only in symptomatics, that is the bottom panel, we saw a 76% decline in week 3 and a 94% decline in week 4. So that during days 22 to 28 after the first dose, we had only 2 cases from 40,000 person days, which is a very low rate. In the Lancet, we published, we had to combine the week 3 and 4 to days 15 to 28 to make it comparable with the clinical publications, but again, a very substantial decline after the first dose. Of course, on the 4th week, the second dose kicks in, but we think most of the impact is still from the first dose because the second dose takes a few days to make it impact. Moving to the last publication that came out last week in the New England, this comes from the largest health fund, the Clalit Health Services. They looked at 1.2 million persons, really doing what we call a controlled cohort. So they took one cohort of vaccinated and they matched a cohort of unvaccinated in many parameters like age, background illness, ethnic illness, place of ethnic background, and place of residence. And what they showed first, these are the Kaplan-Meier. You see that during days 15 to 21 after the first dose, the blue line, which is the fully vaccinated 7 days after the second dose, separates from the red line and flattens. So this is both for all infections, for symptomatic, for hospitalization, severe, and they even saw a significant difference in mortality. All these for fully vaccinated 2 doses. Looking at their point estimates with confidence intervals, we're seeing that when they divided, they saw rate reductions across all populations, most interesting would be hospitalization and severe disease, and even death, where they didn't see any death more than 7 days after the second dose. So in conclusion, a high coverage of population at risk was our first goal, and it was achieved within about a month and a half. The challenges are, of course, special populations like ultra-Orthodox, ethnic minorities. And the second challenge is younger and healthier, because they are less afraid of the disease. So you see on the right a Sky News story about how do you, once in early February, you say everyone can get vaccinated. How do you convince them to get vaccinated? Well, you make it easier. You go to where the young people are, the bars, you offer them a free beer, and they can take the vaccine. A UK variant was the predominant variant in January 2021. So we have good evidence that the vaccine was effective against the UK variant. We did see substantial decline in severe disease, across all both ecologic and effectiveness evaluations. And by that, we conclude the Israeli experience, and I will open the floor for questions if there are any.
Well, thanks a lot. This is very fascinating and very impressive to us, and really congratulating on the work you did in the last months, particularly given the challenges you told us of with a kind of restricted financial background that is awarded to the system. So we are really fascinated. Maybe I would just have one question, one for us in Germany, challenging question, and then give the mic to Anja and Sören. So you have 100% Pfizer, if I got it right. So we are somewhat here again in a debate in Germany about the different vaccinations. I'm aware that there was some data from Scotland suggesting that the same may also work, or will also work actually, with the AstraZeneca vaccination. Do you have any ideas or suggestions in how far the 100% coverage of Pfizer may have affected your impressive results?
Well, it's very challenging to compare what we call them apples and oranges. So we have good confidence in the Pfizer vaccine, and there are limited data from Israel, early data, that suggests that a single dose will exert a relatively good effectiveness on vaccine prevention, so that governments that decide to postpone the second dose of a Pfizer vaccine in order to get twice the population covered. So if you have 2 million doses, you can give one dose to 2 million people instead of 2 doses to 1 million. It actually probably makes sense on a population level to provide good enough coverage and not good enough effectiveness and not excellent effectiveness. To me, that makes sense. Of course, there are other considerations. There's always a concern that a single vaccine with a slightly lower effectiveness will allow variants to develop or to overcome, whereas a very good immunity from 2 doses will reduce this risk. But these are considerations we always take in public health. Regarding the other vaccines, we really don't have experience here in Israel. I did see some data from other countries, but this will really mandate a good, robust evaluation, a field vaccine effectiveness evaluation that I think is not at hand in the moment.
Right, thank you. So maybe I may take over. So thanks very much from my side as well for the impressive data, and I think also scientifically really interesting to see how all these data emerge right now, and let's see how and if they can be extrapolated to the rest of the world. In many European countries, we faced this problem with vaccine hesitancy among certain populations that you also mentioned, and you nicely illustrated this shot at the bar. But did you also see some kind of changing attitude within the population, starting, let's go back into mid-December when everything started? Maybe the confidence into the vaccine was not so well established in the general population. I'm not sure. At least that's what we see in many countries in Western and Central Europe. And how did that evolve? So and perhaps also what type of advice could be given to other countries and nations also in terms of media coverage, and what should be pointed out according to your experience?
Yeah, I alluded to that when I showed that the first citizen to be vaccinated was Benjamin Netanyahu. I think a communication strategy has to be very culturally adjusted. So it cannot be only politicians and doctors. It has to be in collaboration with community leaders, with ethnic minority leaders, with religious leaders. Everybody has to be on board with the communication strategy when you roll out such a vaccine, making sure that it reaches all levels of the population. That's one pillar of a successful rollout. The other pillar is a tradition of trust in the government and in the healthcare. And Israel has such a tradition because we always have a good coverage of childhood vaccines. A 98% coverage for DTP3 has always been the rule in Israel. So people really trust the government for the vaccines. and then make sure this rollout is communicated appropriately. So the science is rolled out in all the media tools, and there is a special unit in the Ministry of Health that focuses on social media and identifies these fake news, these false rumors, and respond to them with real credible data. And then you have to address people who are hesitant, their fears, their concerns, not treat them as enemies, but just people that are intelligent, want to understand what they're doing, and then 95% of them will be convinced if you provide them both the science and also show some personal experience with being vaccinated. All these work as communication strategies, but have to be prepared in advance. It's very difficult to do on the run. Once there's this seed of hesitancy that grows, if you're not prepared, it could be a challenge.
Yeah, right. Thank you very much. And now, in face of the evolving epidemiology of the vaccine landscape, what would you foresee in the future for how our hygiene policies to be changed and adapted, both within the nation with regard to persons that perhaps cannot be vaccinated because of severe anaphylaxis and their past medical history? Will they be required to maintain hygiene and masking, universal masking, etc., while these strategies are going to be lifted for the vaccinated major part of the population? That's one consideration that I think will be of importance also for the world to see how this is going to be managed, as many other countries will probably arrive at that point somewhere later on. And then the second question would also be with regard to international travel, like what's the type of precautions being in place, be it at border controls and especially at the international airport?
Yeah, I will answer. I will divide it to three questions. The first one is the anaphylaxis one. So we provided 8 million doses in Israel. Now, we all know, we are all doctors, and we know that about 30% will report some allergy, some penicillin allergy that some aunt told them about their grandmother, and they have it on their medical file. But in reality, what we did is we started clinics for people with a suspicion of a severe allergy to other drugs. And we provided the COVID vaccines in these clinics. And these were very successful. You did that fully prepared for anaphylaxis with a crash tray and the adrenaline and the defibrillator. Everything was ready. But that way you overcome this challenge and you can actually vaccinate people that have severe adverse reactions. It turns out that when you act like this, there's a very low proportion of people that cannot get the Pfizer vaccine. Then you're left with people that get the Pfizer vaccine, but it's not effective. People on mRNA that cannot develop any antibodies, people severely immune compromised, they get the vaccine, but they're not really protected. This population, you really want to maintain the hygiene, the masking, the social distancing, make sure they are protected even though they were vaccinated. So that was for the second question. The third question is about international travel. I think what we're going to see, and again, Israel is going to be a harbinger here, is we're going to start opening travel to people who are fully vaccinated and do a PCR test 72 hours before boarding. So when they do the check-in for boarding, they will upload the PCR test, and this will be interconnected with a confirmed laboratory. So there are now what they call Safe Pass, and there are some initiatives to allow travel that will enable connecting trusted labs with airlines to make sure that the PCR is not fake. It's not going to be a paper PCR, it's going to be a real connection. Moving on to boarding the flight with an antigen test. So same as we go through a magnometer to make sure we don't carry a gun, we can go through an antigen detection, a 15 minutes antigen. You leave the other side and you enter a fully green terminal. You're fully vaccinated and you undergo PCR and antigen. And then even if you want to, when you disembark, you can undergo another test or maybe 72 to 96 hours after you arrived, another PCR, just to make sure you did not import any virus. Now, this is going to be the beginning, because it still doesn't allow persons from nations who are not vaccinated to travel, and it doesn't allow persons, children to travel. So we're going to start this type of pilot and then move on, expanding the population that can travel while monitoring the risk. And that's how I envision the beginning of Back to Travel. It has many challenges because, again, people who are unvaccinated or nations who are unvaccinated, that puts a lot of restrictions, but there is a balance here of risk and benefit. And we know that for many years, for example, if you wanted to go to Africa or South America, you needed a yellow fever vaccine. So perhaps this would be the model, the international health regulation type model that allows travel for fully vaccinated persons.
All right, thank you very much. Maybe a very last question from my side, if I may. Not really pertaining to vaccination, but rather to antigen-directed also self-testing, because that is an issue that's, at least in the German-speaking countries, very much under debate right now, but still not really fully introduced. Like the self-testing, apart from being restricted to medical staff. What's the daily life in Israel with regard to this aspect? So is that universal testing available? Or is it available in bars or in certain institutions where people normally meet? How's that organized?
So I will say first, it's very easy to get a PCR test in Israel. So if you have any suspicion you need a PCR, that's done within 24 hours. Now, looking at antigen detection is only done by healthcare personnel, never self-testing. It's not available for the public. From my experience, there are different levels of use, so it's a little bit challenging with antigen detection testing. While on one hand, we have common antigen detection tests like a pregnancy test that are easily done in the entire public. On the other hand, when we look at malaria test, for example, we're all familiar with the rapid detection test kit, and we know that there is a very low success rate when you actually let travelers try and do it on their own. So I think the truth falls somewhere in between, and I'm not sure we are, at least in Israel, ready to fully roll out self-testing of antigen detection tests.
Thank you very much. I have two more questions before we finish this interview. And I was wondering what struck you most in this past year of the pandemic, what surprised you? And also, if you were able to go back to March 2020, knowing what you know now, what would you tell yourself or what would you tell the world?
Yeah, so what struck me was the rapid pace of which vaccines were developed and studied. I must say, in my best and most optimistic dreams, I didn't think we will, in March, a year ago, I didn't think I will sit today here having being fully vaccinated for more than a month and a half. I couldn't even dream about it. So that's, to me, a huge scientific achievement of mankind. I must say, I was, in the beginning, just knowing the history of infectious disease and working with disease outbreaks, I was more of a pessimistic back in March when people asked me, is this going to be 1 or 2 months? I told them at least 1 to 2 years before we'll start seeing the end of it. And many people didn't believe me. But just from watching what happened in China and then later in the first countries where the virus moved into, and of course, Italy, when it came in February, it was clear that we're in for a long run. We're not in for a short outbreak. So to me, I hoped people are, of course, always hopeful and optimistic and can think of nature as something that doesn't really respond to our wishes. Nature is nature, and infectious diseases are as such. But so the optimistic end note to this conversation is really the vaccine, which I couldn't have imagined a year ago. And here we are sitting and hoping that everyone in Israel and in Germany will be vaccinated within a few months, and we can go back to relatively normal life.
Yeah, so thanks a lot. This was really, once again, a fascinating talk and very important for us to look at those countries who are really heading again in this fight and giving us even more confidence that we really have to speed up and get people vaccinated here in Austria, Switzerland, and Germany. So thanks a lot. It was a pleasure to talk to you. We are back with our next live interview in German next week on Wednesday 10th. So everybody is invited to participate. And thank you. It was a pleasure having you with us.
A pleasure being with you, and hope to see you soon in person.